recognized authority on radiation oncology and head and neck cancer. In fact, it would not be an overestimation to say he's probably one of the world's most well-recognized and well-respected head and neck radiation oncologists. And so we're really looking forward to hearing what he has to say for us today. Those of us in the audience will have a chance to ask questions, and I'm told by Nicole those online can type in questions for Brian afterwards, and we'll save some time for that once he's concluded.
Thank
Brian.
you.
Are we on the way? So thanks very much for that very generous introduction, John. I'm just having a little trouble here seeing this. Yeah, that's good. Good. So just to put the situation a little bit, I'm even going a little bit more diffuse. It's not just radiotherapy for head and neck. I'm just going to talk about head and neck cancer management in general, things that I think we need to know as radiation medicine specialists looking after these patients that might not necessarily be touched on in the remainder of the talk. So I've tried to guess a little bit about what other people are speaking about, and hopefully I hit the right notes as we go through it. So to kick off, I'll just mention this particular overview paper from Lancet Oncology that I had the good fortune to write with Vincent Gregoire and some of our other colleagues, going through a lot of the different advances in head and neck radiotherapy at present, and going on into the future as well in terms of the concepts that we would like to think we can address efficiently in the years to come, particularly adaptive radiotherapy and tailoring our treatments based on having imaging and other concepts that will bring biology into the target delineation. We do recognize that there are many different aspects of biology that are becoming more and more apparent and are being more and more important in terms of understanding the behavior of different diseases, and are already beginning to individualize the types of treatment, at least for groups of patients, recognizing a theme that will come out as we go through the talk, that not all cancers of the head and neck now are the same. They are differentiating features for a variety of reasons that we will touch on. So, as a very broad statement, surgery and radiotherapy are the two most important tools for head and neck cancer control. Radiotherapy is very effective for treating the primary site to achieve organ and functional preservation, and in some diseases, for example, nasopharynx is the only treatment option in the primary modality. It enhances also surgical option when given as an adjuvant, whether it be pre or post-operatively, and is often combined with chemotherapy, which I will touch on momentarily. But the combination of the two, of course, is quite toxic, and one needs to be careful about who is given that treatment. I noticed I was at a meeting over the weekend, and it seemed to be easier to design the trial by giving everybody chemotherapy as a post-operative management with radiotherapy, and defying the normal principles of management that we would usually use in terms of selecting patients for chemotherapy. And many of us were at a lot of discomfort with that, where some people seem to feel that was fine. And I think one has to be very careful. This is a toxic treatment when you combine the two together. You need to have a good reason for doing it. The new paradigm is that one size does not fit all. Different patients have different behavioral characteristics, different situations, and the current milieu and management is towards having more structured protocols that will look at different outcomes and different needs for different patients, because they don't all behave the same way. And as I mentioned before, we have different biology, which include now the new immune checkpoint inhibitors that are becoming to head and neck as well for the more advanced disease combined with radiotherapy. And that's one of the focuses of the meeting I just mentioned that I was at on the weekend. So the philosophy of using radiotherapy in this disease is really a trade-off in the therapeutic ratio. Eradication of the primary and regional lymph node disease versus the potential for quite extreme damage to normal tissue if you don't do it properly, which is the reason we're all at this meeting here over the next few days. Pharyngeal dysfunction, of course, is one of the great barriers to outcome, to get good function and achieve this goal of organ preservation. And of course, we also would like to preserve other structures as well, particularly bone from osteoradionecrosis risk, xerostomia, and we also recognize that accumulating injury can happen if you combine these treatments. And I'm sure there's a slide that will be shown over and over again from Dr. Trotty's work looking at the TAMES outcome as accumulating toxicity that happens with patients. I will not show that slide because I notice that a lot of people tend to show that slide, and I've left it out. So we do look at the concept of overt disease, which is a gross tumor, and elective disease, where there could be microscopic disease that we know from patterns of behavior and the proximity of the region to the tumor that there could be disease in those areas, and they don't necessarily require the same dose. In fact, we do try to tailor that, as I will mention in a moment. Sometimes there are areas that are at low risk, but maybe actually quite significant if a recurrence is to happen in those areas where there's no opportunity for salvage. So while the recurrence rate might be low, for example, a retropharyngeal lymph node in an oropharynx cancer, you don't have any chance to salvage it if they fail. And so this is the kind of concept in terms of philosophy and decision-making one has to go through. So looking at the types of radiotherapy doses we give, the classic concept of the electric dose region was originated where Steve came from, where Gilbert Fletcher defined the idea of the elective area, the subclinical area that has more has a degree of infestation that may be less than around the immediate part of the primary tumor, and a dose of 50 gray and 25 fractions or equivalent should be able to eradicate it in at least 95% of cases. There are alternative fractionations now which have emerged in a quasi-empiric way. We didn't have any data. They're not really empiric because there was no experience at all. Empiricism should have experience associated with it, even if there's no data. Here we didn't have the data. We just conveniently changed to doses like 56 gray in 30 to 35 fractions or thereabouts when giving IMRT, because that was a convenience. And that has been now in place probably for the last 10 years or so, fueled by many of our clinical trials and so forth. And I think we've become comfortable with it, that it seems to be equivalent to 50 and 25, but we had no data when it was originally introduced. And that's the concept of the single-phase IMRT plan, whereas this was a 25 fraction plan going on to a consecutive boosting phase for the next areas that have needed the gross disease doses. And the gross disease doses should be in the order of about 70 gray and 35 fractions. Again, there are equivalent dose fractionations to that if you give higher dose per fraction or if you give more dose over a more protracted period of time. But this would be the general standard for gross disease and elective doses to the potential microscopic disease, as I mentioned before. It's often intensified by different strategies: altered fractionation, concurrent chemoradiotherapy, or cetuximab, where we have one trial, the Bonner trial, and does not really measure up in terms of the evidence that comes with the other two. Altered fractionation been shown in over 6,000 to 7,000 patients in a meta-analysis called the MARCH meta-analysis, which is a meta-analysis of altered fractionation in head and neck radiotherapy, showing a 3.4% overall effect, but an 8% effect on overall survival if you increase the total dose beyond what is given as a control arm in these trials. And similarly, the MAC-HNC meta-analysis with over 11,000 patients, a 5% overall effect of chemotherapy, but 8% if you deliver concurrent chemoradiotherapy. And these were both done by the same group of authors. They're published in the same journals, the Lancet, both of them. And it's interesting that this here became the standard for all patients with head and neck cancer, and this year has almost been forgotten. And I guess that's understandable at one level, but the problem about this concept of giving every patient with stage 3 and stage 4 disease this approach has now been challenged, because we know they don't all behave the same way. And that's going to come out in the rest of this talk and probably by other speakers as well. And as a caveat also is that the neck is not properly controlled in the MARCH meta-analysis and in all the randomized trials of altered fractionation compared to concurrent chemoradiotherapy. So if you don't respond well in the neck based on imaging, and that's a whole other story about what kind of imaging you should do after the treatment, you may have to be a little bit more aggressive in adding in a neck dissection. That's a little controversial. Part of the problem, I think, was because imaging was not very good at the time of those randomized trials, and the techniques for delivering radiotherapy, with a lot of junctions, a lot of different aspects to how we delivered it in terms of using electrons off cord, all this sort of stuff, did not necessarily treat the target the same way as IMRT does today. So perhaps one could probably revisit that a little bit differently, but the trials are unlikely to get done to be able to show that evidence anymore. And going back to this idea of the full course treatment with IMRT using a simultaneous integrated boost where you have differential doses within the area, and you can give these different doses. We ended up with those 56 grays and 33 or 35 fractions. These are now being challenged even more with a number of papers coming out showing even smaller dose per fraction and lower doses. For example, 50 gray at just over 1.4 gray per fraction being seemingly able to control the low-risk neck, which is something that probably should be considered, hopefully in prospective trials, to look at it more carefully than just in the empiric way I've described already. Let's talk a little bit about post-operative radiotherapy, because that probably is not going to get discussed very much in these couple of days. So there are adverse features like a T3 or T4, and where the resection margin is less than 5 millimeters, where it's close. And we normally give chemotherapy along with the radiotherapy if the resection margins are actually positive. There are also relative indications like lymphovascular invasion or perineural invasion. In the neck, we also have some features that are important, especially multiplicity of nodes, but most of all extracapsular extension, which is probably one of the more adverse features we see in our patients, and these patients would have chemotherapy added to the radiotherapy. And if our surgeons tell us that they were peeling things off, even if the margins are called clear, we don't like that. The surgeons don't like that, and we would ordinarily use that as an indication to treat. Additional considerations also, and this is probably something that is not normally talked about very much in the tumor board, please get post-operative imaging before you give your radiotherapy. It's necessary to guide the adjuvant treatment. You may see regrowth happening before you get started. You see that little node in there that's getting bigger, that wasn't taken out. You don't want to see overt disease still there that has not been resected, because that will require the 70 gray type dose. And we will often have to tailor the doses in a way to give 70 gray to a small area, and then the more traditional post-operative doses to the main area, and elective doses even. So you could end up with 3 or 4 even dose levels if you find this kind of situation. And this is all based, in terms of the concepts here, on 2 New England Journal of Medicine publications from the RTOG and the EORTC, published back-to-back, one issue of the New England Journal some years ago. So what sort of margin principles do we take into account in terms of designing margins? Well, we're all familiar with these concepts, the GTV and the CTV and so forth, but it doesn't tell you how much width you should give in terms of the coverage of these areas using the ICIU 5062 principles. And the planning target volume set up motion uncertainty. In this institution anyway, we do not put planning target volumes on. That's put on by our planning team and our physicists and our radiation therapy planners. The physician sticks to putting the targets on that are the areas where the disease is or might be. In other words, the high dose CTV and the more moderate elective CTVs and so forth. And we'll end up with this kind of arrangement with primary disease getting 70 gray for gross tumor, 66 in the post-operative setting, depending on the margin status. If it's positive, we'll give 66. And we normally keep it reasonably close to the where the primary used to be or where it currently is, depending on whether it's adjuvant treatment or primary treatment. And then we get back to that 50 to 56 story that I told you about already, depending on the fractionation, which we would call the elective CTV, and normally about 1 centimeter from the current tumor or the site of the original tumor that has now been resected if it's a post-operative setting. And similarly in the neck, 70 gray, we give 5 millimeters around gross disease or the original sites of gross disease based on the imaging reports that we have. And again, 60 to 66 depending on the situation in terms of risk. When we're in the post-operative phase, if the patient has extracapsular extension, they get 66 gray or 60 gray if they don't have that. And the elective doses again are shown here as I described already. Now, if they're in the post-operative setting, we change things a little bit, because if they've had dissection, we give a somewhat higher dose. And I'll show the basis for why that is the case in a moment. And then the most low-risk area, uninvolved, undissected, will get doses in the order of 54 to 56. We normally give 56, but 54 is very reasonable as well, based on the data that we have available to us. When trying to make decisions about IMRT contouring, or in fact any kind of contouring for that matter, but I guess we all do IMRT now, and that's what we're talking about today. Gross disease, you look at your imaging, you look at your image fusion, and in the post-operative setting, you talk to the surgeon. You try to find out as much as you can about where this tumor was and what the problems were. Contouring guidelines are available. We've revised the international consensus guidelines about a year and a half ago. Dr. Gregor and a number of us from all the different cooperative groups put together a more expansive guideline delineation document for the neck. And there's, of course, still some inconsistency in what should be the high-dose CTV around the primary, because we really don't have any data on that. We tend to borrow from what we do in the neck, in fact, to do that. And the neck disease, the neck situation is not that plentiful either in terms of data, but it does come from this one paper from the MD Anderson published some 8 years ago or so, showing that a 5mm margin will take account of pretty much all the clonogenic density area around potential extracapsular extension around lymph nodes, and that's the basis for the 5mm that we will use around neck disease. There are also some interesting issues about what volume should be used post-induction, and taking into account the scar, how much bolus should be used, if at all, and contaminated surgical bed. And these are a little bit empiric, and you kind of wing it a little bit on these because they're not very well defined. And we don't like causing moist desquamation in the neck where we don't have to, especially if it's going to cause cosmetic problems afterwards, which it often can. And the elective volumes may also need to be compromised in some patients. The elderly, the poor performing patient, in terms of status, poor performance status, may not be able to tolerate very large swaths of areas being treated on an indiscriminate way just because they might happen to have disease. You've got to come up with some better recipe for these patients. Elective volumes, however, might be reasonable targets if doing adaptive radiotherapy, for example, because they're elective targets, they're not gross disease, and as you adapt radiotherapy, especially when patient is getting, when there's shrinkage of disease or if they're losing weight and so forth, you may well be able to change the elective target, but you can't change the gross tumor target without some degree of concern. And here's the paper from MD Anderson that I did mention, which affects the postoperative design, especially for lymph nodes. I'm sure Stephen's quite familiar with this. There are very few papers like this in the literature, but it shows that out to 5mm distance from the lymph node capsule is basically where you should stop seeing the cumulative degree of extracapsular extension. This is a very carefully done old-fashioned study, which I like a lot, and I like to show it a lot because it shows some real information that you can now use to exploit in terms of making decisions about how much coverage you need beyond where lymph nodes are or where they used to be before they were removed. And we tend to extrapolate that a little bit to the primary as well, but we don't have similar data that's as good, at least, for the primary. And I mentioned before that you may have to adapt things a little bit in the elderly. Here's a patient, an older woman of 80 years of age, who I had to plead to let me give her treatment with a tonsil cancer coming to the midline, and I just treated the opposite neck to a very modest area in level 2 to deliver the elective dose, and I kept the other targets small as well. I didn't treat very far down into the low neck either, and we controlled her disease. So these are situations where you have to use common sense because you won't get these patients through treatment, or if you do, they will suffer hardship for the rest of their life. These are not very robust patients, and you have to be careful with them. So I'm also going to talk a little bit about some milestones in postoperative adjuvant radiotherapy with or without chemotherapy, because I doubt if that's going to be talked about here at this session either. And a lot of people aren't as familiar with this who might be attending the course. So radiotherapy combined with surgery began some 60 years ago, appreciating this risk of recurrence following surgery alone, especially in oral cavity cancer and in other diseases like larynx cancer and so forth. Postoperative radiotherapy is punctuated by a number of important trials. The RTOG ran RTOG 7303 back in 1987. It was a pre-op versus postoperative radiotherapy trial, and higher doses postoperatively were deemed to be the superior approach, and has basically been the standard ever since. MD Anderson ran a randomized trial, published a classic paper, which basically is probably the most important trial that we have to go by in terms of the dose specification, authored by Dr. Lester Peters, looking at dose modified according to risk stratification by pathologic features. Probably the first paper in the literature looking at risk stratification according to features, and it was subsequently validated by a paper that was published using a slightly different strategy, but by Dr. Kian Ang, our good friend and colleague, who unfortunately has now passed away. And this trial here by Dr. Peters is, I will show you actually some of the data from that in a second. There's also a trial from India, and I'm just speaking to one of my colleagues here, Srinivas from India, to find out where Orissa is. It's on the east coast of India, and there's very few data looking at randomized data as to the justification for why we can give post-operative radiotherapy. This is surgery alone versus surgery and post-operative radiotherapy trial. And then I've already mentioned these landmark trials earlier from the RTOG and URTC establishing the role of chemotherapy, but the evidence for the value of chemotherapy in fact seems to diminish with long-term follow-up. Dr. Cooper's original paper in the New England Journal, it does not hold up at 10 years as published most recently in the Red Journal. And that's a worrying feature because we haven't changed our practice because of this update. Or maybe they would have done worse, I suppose, if they didn't get the chemo. I don't know. But the problem is that they are not, the curves are coincident now after 10 years, which is a worry because it didn't hold. And we're still exposing patients to this sort of toxicity that we worry about. There's the study from India. 140 buccal mucosal patients, stage 3 and stage 4, and you can see the 3-year overall survival for surgery versus post-operative radiotherapy. There's about a 10% difference. It's an underpowered study. It's not significant, although the degrees-free survival does show significance. So this is the only trial that we really have to go by justifying it. But I think common sense tells us that this is a valuable treatment, even if the trials are not available to us. And that's one of the problems that we do have, especially in traditional treatments of this type. Here's Dr. Peters' trial, a classic trial that I mentioned, which has basically governed and informed us about the need to have risk-stratified radiotherapy. Now, there was no chemotherapy used in this trial. The trial was a randomization to arm A and RB for low-risk disease, that would be the close margin type, not so bad, the nodes not so bad, versus higher risk, positive margin, extracapsular extension type situations. And up till the first interim analysis, they had a dose of 52.2 for arm A in this trial, and that was abandoned based on an unacceptable number of failures, even in this low-risk group. So they ended up, in fact, being able to compare the 52.2 versus these other dose schedules, and came up with a number of observations and recommendations. First of all, the undissected at-risk neck area can be safely treated with 54 gray. And the reason I say at risk means it could have disease in it, but it was not dissected, and there was no overt disease there. 54 gray at 1.8 seems to be adequate. Higher local failure can happen if you drop the dose compared to if you go up to the higher dose ranges that happened at this point in the original dose, the subsequent dose A arm. Extracapsular extension needs at least 63 gray. There's no apparent dose response above about 58 gray, except for extracapsular extension. Now we tend to ignore that. We go higher. We go to 60 gray. Right? Because in the modern era, everything is bigger and better and stronger and more intense, and we give chemo and all these sort of things. So there's a bit of a problem that this is the data, but we've all give more. And of course we cause toxicity. But at least this is the basis for the decision making that we take. First, risk-stratified trial that we have to go by in this area. And there are clusters that exist. For example, a number of different features. More than 2 adverse features, you get an increasing risk. If you get more than 4 features, even if they're all kind of just okay things, they still have a recurrence rate that's equivalent to extracapsular extension, which is the worst scenario of all. So there are different types of situation that might guide you into giving more intensive treatment, and not just the classic one of a positive margin or an extracapsular extension. And maybe some of these should even be considered for chemotherapy if you believe chemotherapy is useful, if they are having this kind of recurrence pattern. So looking at the overall management philosophy of a patient who comes in, there are a variety of different issues about the disease, about the patient's condition, and about what resources and infrastructure you have available, and the goal of the treatment, whether it be cure versus palliation. You want to look at disease control versus function preservation. You want to look at the available options, looking at standards and alternatives. You go to the institutional tumor boards and protocols and so forth that we have and the expertise you have available to you, and you hope you can come up with something that is useful for the individual patient. There are a variety of issues prior to making decisions: the treatment options, the radiotherapy volumes, the possibility of adapting to things during radiotherapy, and then monitoring outcome and having good data afterwards. And this is a slide given to me by Dr. Sophie Huang, who will talk about the anthology of outcomes tomorrow, who runs our database, and she created this structure, and I just borrowed it because I think it's a nice overview of what we should be thinking about when we see a patient coming in for the first time. And radiotherapy for this disease is evolving. Previously, we took everything as being the same except for early stage versus advanced, or surgical versus organ preservation, the post-op or the primary situation. Now we recognize this heterogeneity. I mentioned a number of these before. The PD-1 and PD-1 ligand expressing tumors having a higher risk of recurrence. We're now borrowing the concepts from melanoma and other diseases to be able to possibly combine those with chemotherapy in addition to radiotherapy in the highest risk situation. And we have a lot of other issues about human papillomavirus, hypoxia, Epstein-Barr virus, and the quantitation of that in the plasma. Even stem cells may even become something that is used in the future. And a whole lot of different nuances of treatment and different types of patients, some of whom, as I mentioned earlier, may not be able to tolerate treatment as you might want. And when we make these decisions and we talk about all these wonderful new things we're discovering, we shouldn't forget that we also have a few patients that we're almost never talking about anymore or haven't talked about yet, and they are going to be the challenge for the future, especially the older patient, where you need to come up with this balance that I mentioned earlier. And the HPV negative patient needs strategies to improve their local control and their distant metastasis rates. I'm just going to talk very briefly about this recently launched trial that's being run from the RTOG, now the NRG, in nasopharynx cancer, looking at whether or not Epstein-Barr virus is expressed or can be quantitated after they finished the definitive treatment. This is an elegant trial that uses a harmonized approach to the laboratory assessment of EB viral copy number in the blood with a randomization depending on whether it's negative, going to the traditional treatment, cisplatin 5-FU as an adjuvant afterwards, or observing them in a phase 3 format, which will accrue about 600 patients. And in the less common situation, patients who have still Epstein-Barr virus in their plasma will be randomized to the traditional chemotherapy given at this point versus a more intensive treatment with gemcitabine and paclitaxel. This will be a phase 2 component with about 100 patients. And this trial is currently running. It's a very elegant trial that basically are being PI'd by Nancy Lee at Memorial Sloan Kettering, but a lot of the effort has been given by Quinn Lee, who's the current chair of the NRG head and neck group. So this is going to be an interesting trial. Again, a new concept in terms of looking at risk stratification to choose patients who need treatments that otherwise they would not necessarily require. And that decision has to come down as a randomized trial, I think, is the way to address this. And this strategy could be used for other diseases as well. It'll be the first time that we've looked at this. It's really like an extension on from Lester's original trial with the post-op setting. HPV de-intensification is a huge problem at the present time. It's been fueled a lot by the fact that we know these patients do extremely well, but they don't all do so well. And there's a profile which was established by the RTOG and Kianang on the 0129 study, looking at a very good risk group with only a 7% failure rate or survival deficit. And these are overall survival and progression-free survival for the HPV positive patients who are light smokers. But then there are intermediate risk patients that don't do as well. And then there are high-risk patients with HPV negative tumors who don't do well either. And you can see these groupings or stratified groupings that you can see with the low risk, intermediate, and high risk. And one of the big concerns, of course, is with these excellent results that you're getting, for example, in this group, be recapitulated if you stop giving the intensified treatment. And that's guiding the entire approach to this group of patients at the present time. So, for example, we've looked at this, looking at a slightly different view of it considering the risk of distant metastasis in the whole group of oropharynx cancers. And this is a recursive partitioning analysis looking at HPV positive, HPV negative outcome for distant metastases, which they do pretty well. But you can bring it down through the N0 to N2 group, and then on down into the T1s and T3s, and you can find this very favorable group. Here it is here, with a 7% likelihood of getting distant metastasis. Sounds not too bad. But if you look at this more carefully, and look at them up to N2A, there are patients who did not receive chemotherapy because they weren't able to tolerate it. They do extremely well, no matter whether they get chemotherapy or not. This actually is the chemo arm here, but they're essentially the same. It's not any different statistically. If you look at the N2Bs, you're beginning to see a bit of a trend. It's actually significant on this. It's about a 10% difference between the two, 98 versus 89%. And N2Cs, it's basically about a 20% difference between the two in terms of outcome if they didn't get chemotherapy. Now, this is retrospective data. There could be all sorts of reasons why it's happened, but nonetheless, it's happening the way you would expect it to happen. The disease is showing its form and character. And when you look at this even more carefully, this group here, according to smoking status, those who did not smoke or only light smokers have almost no risk of distant metastasis. And if you look at the heavier, packier smokers, you're seeing a behavior that's not dissimilar to the N2C group. And now, because of these data, we've looked at this kind of concept of some way of breaking this logjam on de-intensification. There's one way it at least merits a different treatment strategy in terms of randomized trial approach. I call it the Rosetta Stone, or the key to unlock the mystery of how we're going to get through this, because we haven't been able to look at a good way of addressing this problem until now. But distant metastases does come up as being a realistic problem because it's the most common cause of death in HPV oropharynx cancer compared to the traditional local regional disease. So this can identify subsets of patients with different risks of distant metastases. Those who you might omit the chemotherapy, who don't have the risk, versus ones who do need systemic modulation to their management, whether it be chemo and or other treatments. I alluded to a few a moment ago with the PD-1 and PD-1L checkpoint inhibitors that might be combined with cisplatin. But whatever the issue is, we've got two groups of patients that are split by looking at this kind of analysis. And this is now underpinning the design of clinical trials in the North American environment to address this particular important group of patients. The most obvious one being this very recently launched trial from the RTOG, now called the NRG-002. It's their second trial as NRG, as you saw the first one a moment ago with nasopharynx cancer. This is being led by Sue Yom and Maura Gillison. John is our co-chair from Canada, and it looks at that exact group of favorable patients, oropharynx, that I described a moment ago, who are not heavy smokers, and is a randomization to a more modest form of chemoradiotherapy versus a radiotherapy alone approach, even with a lower dose. Now, this is based on the data, in fact, from the Princess Margaret, 60 gray given over 5 weeks, showing very high rates of control. And of course, it's a daring move. It's not the traditional approach. This is a strong and controversial move to try and get de-escalation for a group of patients who have very few events at all, in fact. Now, another little interesting aspect is this here, a stratification to unilateral versus bilateral radiotherapy in tonsillar cancer that's lateralized. This is, again, a new concept in a clinical trial. It hasn't been done before. And you notice these little pictures that have just emerged here when I did that. Now, I'll just comment on that in a second. But this idea of unilateral radiotherapy versus bilateral, it was quite interesting, because some people, when we're designing the trial, were absolutely adamant they would not support this trial unless this concept was in there. And they're quite well-known radiation oncologists in North America. They said they will not support the trial. They won't put patients on unless there's allowance for this. So this is an interesting change that's happened, because way back we wrote this paper, it's now almost 15 years ago since we did this study, showing that contralateral neck failure is almost never seen when you give unilateral radiotherapy if you choose them properly according to the degree of medial extension that happens. And here's an old technique. You probably find a mask like this down the corridor down there in that little museum thing, and you'll all laugh at it, but this is the job, right? It treats the unilateral neck and primary, although, again, we call it there are some pitfalls according to this, and I'll comment on this in a second, recognizing the fact that you do need to cover the primary properly. And so you see coverage of less than a centimeter or more than a centimeter here over the years, and became less in the latter part of the study. This is retrospective, so nobody was controlling for what was happening. This is basically individual doctors doing their own thing. And you can see that if you had less than a centimeter of coverage on the primary, you had a control rate which was disastrous, down to 30% local control, compared to almost all patients if you had adequate coverage. So that goes obviously without saying that that's an important issue, and it actually changed our management here at Princess Margaret for all our patients with head and neck cancer. Just the move to this particular lower incidence of this poor control of the disease, in fact, coincided with the introduction of written policies, which we had introduced in the late 1980s, and basically described what you should do to get coverage of the primary. And it required, in fact, a 2 centimeter clinical target volume coverage on the primary in the way we used to plan at that time. And we also forbade the use after that of planning these patients without planning CT. It's changed, because we were just getting CT simulation at the time. So it changed a lot of what we did based on this, not just defining the low risk of contralateral failure, but also the way we should plan the primary, and introduced the concept of the QA rounds, which happen in this room every Monday morning, once a week. We have them here. It's real-time audit on the cases that are presented, and the cases are very clinical. The imaging's looked at. We look at the contours as are relevant, and we need these because we do make mistakes. Everybody can make a mistake, and we try not to have an aggressive approach to this. We all want to treat these patients successfully. And it becomes more of an issue as treatment complexity increases and we have the risk of not controlling disease. And this is, of course, borne out very much in this more recent paper by Lester Peters that we put a lot of patients on the trial, and we performed a QA process. And there were 850 patients on this trial who all had real-time QA and then after treatment QA as well. And it was a huge effort to try and get this done. And we had to call in the cavalry here from Princess Margaret to try and get part of this QA done, because we were the closest center to where T.J. Fitzgerald works at Providence, Rhode Island, for the Quark program. And so Drs. Cummings, Kim, and Waldron also joined me, because we're the 4 closest to the center to complete the QA on these patients, because others had to come from Australia and Europe and so forth. But you can see the effect of poor coverage, protocol violation on local regional control, 24% impact that converts into a 20% survival advantage or disadvantage if you don't accomplish that. It's got nothing to do with any chemotherapy or anything. This is just bad radiotherapy. You're going to get results like this. So you really do have to be vigilant about this. And if you've got centers accruing a lot of patients, you can end up with a very different outcome to centers that are not familiar with this approach. So again, highlights why we're all here listening to these courses these last few days. Now, there's been a change also in OPC that we're all going to have to deal with. So classically, we give concurrent chemoradiotherapy. Now we're going to have to face the interesting experience of transoral robotic surgery or laser excisions of the primary site transorally as well. And there are a number of trials that are emerging in this way, which I'll show in a second. But they do cause a problem for us, because we do have to have some reason and rationale for why we're going to give, or if we're going to give, any adjuvant treatment subsequently. Because the idea is to de-escalate their treatment. And for a very small tumor with very little risk of lymph node involvement, that sounds very good. But for patients with bigger tumors and overt disease, especially extracapsular extension, it's not so good. So, and I'll explain why in a second. So here are 2 trials, one from ECOG and the other from the RTOG. One is for HPV positive and the other for HPV negative. The stratification, the treatment approach here is to do TORs on every P16 patient with limited disease. They're small volume, T1 to 2 up to N2B. And depending on what is found pathologically, they go into a low risk category, intermediate risk, or high risk. And within the intermediate risk, they get randomized to 60 gray or 50 gray. And no chemotherapy. And these ones here are observed, which is nice for those patients. these ones here get concurrent chemoradiotherapy. So they've ended up now having 3 modalities of treatment for an early-ish oropharynx cancer. And in the HPV negative group, you could basically take this particular algorithm without the randomization, that whole part, that entire bit is randomized against concurrent chemoradiotherapy. So this is a higher risk group, HPV negative, again, early disease, and these 2 trials are currently ongoing and accruing, although the accrual is not good for this one so far, and probably because centers that have TORs aren't necessarily seeing a lot of HPV negative patients, who tend to be in centers that are maybe have more smokers and alcohol abusing patients who have this traditional form of the disease. There's also a Canadian trial that does not differentiate the 2, but basically does the same approach that we saw on the Holsinger trial for HPV negative, radiotherapy and chemo versus transoral with risk-based approach, exactly the same risk-based approach. And you can see the different strategies for those 3 trials, all very similar. What is interesting is these 2 have been harmonized to have the same resection margin status to decide whether you're going to survey them or not. They've made the effort to try and make them the same, at more than 3 millimeters being, or equal to 3 millimeters being the criterion for being able to survey a patient and not give them radiotherapy. There's some little differences in the intermediate risk category, but the high risk is, again, for all 3 established by positive margins, extracapsular extension, and bad things that need concurrent chemoradiotherapy as we would normally do it. And again, remember, these patients are relatively early disease, and the ones down here are going to get all 3 treatments. And in fact, a lot of patients are found to have lymph node involvement, and they need more than just the TORs. The group that get TORs actually are the smaller of the smaller proportion of these. And there are a number of uncertainties, of course, because the appropriateness of this risk stratification is based on very limited data. The definition of the resection margin is also very poorly worked out now. There's some retrospective series. We don't know. We don't have a robust, long experience to know if this safely can follow these patients without radiotherapy. A little comment on the evidence for using IMRT. So we put this practice guideline into the ministry to get IMRT funding for all patients in this province, and established that xerostomia and quality of life are clearly determined in randomized trials as being improved. Blindness and osteoarthritis necrosis should really be very uncommon with properly delivered IMRT, and there's now an overall survival advantage in one trial, a big robust trial from Wuhan in central China, looking at 616 patients accrued over a 5-year period, all stages, 5-year outcome showing a survival advantage, and with significant impact on a number of important morbidity issues that include hearing and xerostomia. So this is a level 1 evidence for the use of IMRT in nasopharynx cancer that is as good as anything that might come from other sources. A final little issue is, why do we fractionate radiotherapy? We fractionate radiotherapy, and I put this in because it doesn't get emphasized anymore. We want to go on into stereotactic, and we give big doses, modest amounts of volume, and we think we've done a good job, and that's fine if the volume is small, but we have to be worried about the normal tissues when we do this. And also, concurrent chemoradiotherapy has basically covered over all the issues we've traditionally known about fractionation, and it doesn't get discussed very much anymore. But just to remind you of the 4 R's: repair, reoxygenation, redistribution, and repopulation. Repopulation is potentially something that we have accelerated fractionation to combat, and repair, basically with fractionation and of course hyperfractionation with small dose per fraction, protects against late tissue damage. And you might say, well, what's the evidence for that? Well, I'm going to show you some evidence in a moment. So late responding normal tissues have a lower alpha-beta ratio, typically around 3 or less, compared to tumor, which is around 10. And we use smaller dose per fractions to reduce late toxicity. And this is a trial that got us into the March meta-analysis, the 5-year results of a randomized trial. We looked at the smaller dose per fraction, augmenting the total dose, and showed no increase in late toxicity. But we did get an increase in local control of over 10%, and we had an improvement in survival. And this improvement in survival, while it hasn't maintained as the years go by, it's the longest follow-up trial in the March meta-analysis. It's significant still. The local control has maintained out over 15 years. with a 10% effect, and no deterioration in late tissue effect, despite an improvement in control by pushing the dose. So the fractionation has protected late tissues against damage. There are also other issues that happen in long-term follow-up that we need to be aware of. In particular, the fact that patients do get other causes of mortality other than their cancer, and we may misinterpret non-cancer death as treatment effect, which is important because progression-free survival is often used as an endpoint in trials, and this may actually be a problem for even the HPV-positive patients because many of them are, in fact, smokers. So as we move into the future, we need to try and get the balance right in optimizing the therapeutic ratio. We're trying to take pressure off in terms of the intensive treatment, maintain our local control, however, but we do worry about whether we can do that safely. So clinical trials need to be done. So consistent application of radiotherapy and surgery with emphasis on quality remains an essential part of the management of head and neck cancer. There are present and evolving systemic agents to facilitate treatments, but there are costs and they're toxic. Toxicity continues to be our greatest barrier, our greatest enemy in this whole area because of problems with pharyngeal function and so forth, even in the IMRT image-guided era. The fundamental principles of head and neck cancer management must be remembered. Even for the new targeting approaches and individualized treatment, don't forget what needs to be treated. Don't forget fractionation, the adequate dose, combining it with other treatments, and so forth. Clinical trials and evidence are the vital underpinning of all these decisions, and we should continue to work in a multidisciplinary way. So thank you very much for your attention.
Thank you, Brian. I just want to note that I haven't got any questions from the attendees online, so
that's good.
We can open it up for a few questions from the audience if there's any burning questions for Brian this morning.
Excellent webinar and overview. When we start thinking about dose de-escalation and moving that 60 gray down to 60 gray without any chemotherapy, what are your thoughts about the acceleration of 6 days or 6 fractions per week, as opposed to just going 5 fractions per week? What do you think that added acceleration may offer versus just de-escalating it, with standard fractionation?
Well, there are two elements to that. The first is that the data is based largely on the safety in terms of efficacy from this hospital using a fractionation regime that we don't currently use very often, which we basically have borrowed from our colleagues in Vancouver, which is 60 gray in 5 weeks. Given a 2.4 gray per day, 5 fractions per week. I don't know if that's the type of 5 fraction per week you're thinking of, but that's a 5-week course given 5 fractions per week, moderate acceleration, but 2.4 gray per day. And if you do the linear quadratic equation, the BED calculation for that, it's exactly the same as 60 gray in 5 weeks given as 6 fractions per week. They're identical. But for late toxicity, and we do see some late toxicity with that approach, especially when we're treating around the larynx and so forth, maybe not so relevant in early oropharynx cancer, but we do see some edema, and we do see some, I at least see, I'm a bit biased about it because I've had a few patients, 3 patients in fact, that ended up having temporary tracheostomies, and I think we all get a little bit where we see fibrosis and maybe the voice not being quite as good in a larynx cancer when we give that treatment. So the idea of the 6 fractions was really to keep the dose per fraction at 2 gray per fraction, as opposed to giving it as 2.4, 5 fractions per week. So that's got about that BED is significantly different. I think it goes at around 100 versus 110 or something like that. There's an appreciable difference between the two. From the point of view, I think it's in the protocol too as well, isn't it? Those BED calculations. If you look at it on the RTOG's protocol. Scott?
Do you ever consider a hyperfractionated regime in the initial treatment of patients, or do you just keep that for retreatment?
Yeah. Okay. So what Dr. Brackman has asked is, do we consider hyperfractionation in the initial situation versus compared to only using it for retreatment. And the answer to that basically is yes, we do, but we don't do it commonly. And now there's also an issue about what constitutes, or how do you define hyperfractionation. So the most classic version of it in North America, based on the 1903 trial done by the RTOG many, many years ago, would be to use 1.2 twice a day and going up to doses over 70 gray with that. We have never done that here. Our hyperfractionation was always a 4-week fractionation, and it comes from the way things developed historically, that was the type of treatment approach done in this hospital before chemoradiotherapy started. So our hyperfractionation is pure hyperfractionation. I don't mean that in any kind of peculiar way, but it's given in 4 weeks before accelerated proliferation starts. So you don't have any wastage of dose as you go on out for another 3 weeks, which happens with the 1.2 BID version. The two schedules that I showed you there in that randomized trial were 4-week schedules. One of them hyperfractionated at 1.45. I think it was 1.45, I believe, wasn't it? The fractionation twice a day to 58 gray versus 50 gray given in 20 fractions daily. We call that pure hyperfractionation. And we have a schedule that's a bit more intense than that. We call it hard wins. Very similar to one of the arms of the Gore-Tex 3-arm trial that they published some years ago, which shows a very similar local regional control to chemoradiotherapy. So in a patient who's not able to have chemotherapy and who's sufficiently robust in terms of their ability to withstand the treatment, we would probably consider that over something like cetuximab and radiotherapy. We would think that's a more powerful treatment, again, based largely because of the Gore-Tex trial.
Okay, so thank you very much, Dr. O'Sullivan. Brian's going to be at the Wine and Cheese, hopefully, and at the dinner on Saturday night. So you'll have more time to pick his brain. And that was such a comprehensive overview that we're just going to skip my introductory section now.
Sorry about that.
Skip the whole course now.
Well, yeah. Well, the technical aspects need some addressing, and we have 2 very important members of our group, Kim and Eric Bartlett, who come to talk to us about the issues I was going to introduce largely, which is all about the volume.